Hi, Assalamualaikum and a very good afternoon to all our Sinar Daily's Life and Style podcast viewers. Welcome back with me. I'm Dr. Nur Hamizah Zulkifli, will be your host and your moderator for the session today. So the topic today is infertility, in vitro fertilization, the journey, the science, the hope. So the reason why we chose the topic infertility is because this is to celebrate in conjunction of the World Infertility Awareness Month, which we celebrate in the whole month of June. So going to the statistics, globally we know that 1 of 6 people, approximately about 17.5% of the adults, are experiencing infertility, affecting both men and women across the country and also all the region and income levels as well. Female infertility is a significant contributor, particularly concentrated in medium to high socio-demographic index regions, including the East of Asia. And as we all know, worldwide, the number of the fertility rate is declining tremendously, and Malaysia also is one of the statistics. So, infertility is more common than what we think of. But it's rarely being spoken about, and also it's rarely being, people, they keep to themselves. So because of that, this is why we have our expert panel today, Dr. Natasha binti Muhammad Noor. She is a specialist in reproductive medicine, as well as also an obstetric and gynecologist from KL Fertility Center Damansara. So at the same time, she's just not only a fertility specialist, she was a patient who undergone the fertility journey and had underwent multiple IVF procedures, right, Dr. Natasha?
Yes, that's correct.
And Alhamdulillah, she had given birth to a pair of twins, and they are now in their teens, 14 years old.
Yep.
Alhamdulillah. Okay, so in this session, we will try to unravel the fact, debunk all the myth as much as we can, and also to walk through the emotional and medical journey of the patients. Of how the patient would be experiencing throughout the infertility journey, and especially in today's Malaysian context. Whether you are planning to have a family, you are a part of the TTC, trying to conceive warrior and fighters, or you are also supporting maybe your loved ones, your friends, or you're just someone who's curious about fertility science, this is the podcast that you don't want to miss. Okay? So without any further ado, let's dive into the matter per se. So my first question to Dr. Natasha, can you explain the different types of infertility? Because we know we have male infertility, woman infertility. We also have the unexplained ones. It's not neither man, neither woman is the cause of it. So, and how common each in your practice? Each of the category. Because when we talk about infertility, common perception is, it's always the woman. They will always shift to see the woman is the problematic ones. But from your experience, could you just elaborate in terms of this, Dr. Natasha?
Okay, so in terms of subfertility, we have a few causes. In general, we would divide the causes of subfertility. 30% is due to female causes, 30% and increasing, it's due to male causes. A combination of male and female, another 30%, and also unexplained, perhaps about 10%. So like you mentioned, lots of misconception is always the female issue. So, but I think more and more that we have issues with from the male side. Okay. So when we are investigating for subfertility or infertility, we do emphasize that the male partner comes, and one of the things that we would want to investigate is doing a semen analysis to just make sure that there are no issues from the male side in terms of their sperm number, quality, and their movement.
Okay, so like you said, 30% are from the females, 30% also nowadays is from the male.
And increasing.
And increasing. So bear in mind, it's not 70% female and 30% male or 0% male. So it's almost equal nowadays, yeah?
Yes.
So men also should come, like you said, during the fertility assessment to get their sperm check, right?
Yes.
Okay. So in Malaysia, since you have talked about the infertility, the percentage for men and women, so what are some of the most common causes and etiology of infertility that you have seen in Malaysia nowadays, or in the recent past decade? I would say, over the years in Malaysia. For example, the lifestyle that we have going through. I mean, nowadays everything is always, we are always on the move. There's stress, and then obesity. I mean, malnourished or overnourished also is not. I mean, it's a problem, isn't it? So, and also late marriages. We can see nowadays, not just female, males also, they are going more towards late marriage. Married at the later ages. So, does this also impact the fertility rates in Malaysia?
So I think there's several causes. One of the more common things that I see would be, I think quite a lot of those who are under the fertility journey knows, it's called PCOS or PCOS. So this is a term to basically a condition where there is ovulation issues. The female does not ovulate, and the reason for this is mainly due to hormone imbalance, and one of the main reasons are due to actually have excessive weight, overweight or obese. Like you were mentioning, we are actually we're the king and queen of obesity in Southeast Asia, and we have been reigning champion for the last 6-7 years. Something that I hope to actually create awareness, public awareness, that we do need to tackle this issue, because it will affect across the board, not in terms of other medical illness, but also in terms of fertility. It's very reversible, so something that we should address. So aside from the PCOS, also, like you're right, there's a delay in settling down. Maybe perhaps get married earlier, but things happen. You're working, you're trying to settle down. So there's not only a delay in marriage, a delay in actually starting a family. So both increases in age. This would actually cause a reduction in egg quality, your egg number. Not only that, men always also have their own biological clock. So men also will have a decline in their sperm when they hit 35 to 45 years old. Apart from female, unfortunately, it's a gradual, but we start to have a gradual decline by late 20s.
Late 20s,
yeah,
okay.
much earlier.
Yeah.
But a bit more prominent when we're perhaps about more than 35 years old.
Okay, all right. So I guess Dr. Natasha already covered my next question, because we were talking about the biological clock. So having said that, because normally we also think that the biological clock is for the females, because they will reach their menopause age, whereas the men can produce sperm throughout their whole life journey, isn't it? But like what Dr. Natasha has mentioned, the sperm quality will reduce at the age of 30 to 35. I mean
around that age.
Around that age. And also, but the females is much more earlier, at the age of 20.
Unfortunately, females, the main difference is we do not reproduce any more eggs.
Okay,
we are born with all the eggs that we have, even though when we are in our mommy's tummy, right? We already are all millionaires. All female have had 1 to 2 million eggs within us. But as soon as we hit reproductive age, it drops down to 300,000 and declines with each month, despite us using or not. For male, yes, unfair or not being fair, they reproduce daily, right? They reproduce daily. But when they get a bit older, the reproduction becomes less efficient. So they will produce perhaps less sperm, or perhaps a less quality sperm, right? And also for male, even though they can have babies even the age of 80, right? But there are increasing studies to show that male partners who are older and trying to reproduce or having babies, there are increased risk of fetal abnormalities, such as autistic, and also mental disorders such as schizophrenia. And not only that, also there are increased risks for the female partner during their pregnancies, such as preeclampsia, which means severe high blood pressure, miscarriages. So male do play an important role. So we want to have both partners conceive as much as possible at an earlier age because of all our biological changes.
All right. So having said that regarding the biological clock, so that's where the next question would be. When is the right time for the couple to actually seek medical attention? Because like what Dr. Natasha mentioned, they might be, they are married early at the age of 20s and 21, 22, but they decide to be, because they're only 20s, so they probably want to wait until a bit 28 or 29. So, but when is the time that they have to it's like a ring a bell. It's a red flag sign. Maybe after a year of trying to conceive, well, we call the infertility period. They can't conceive naturally. So when is the right time for them to actually embark in this infertility journey?
Okay, I suppose we do have guidelines, but right time means different thing for different patients or couples. So if you feel you are at all concerned, you can go at any time. But the guideline is if you have regular cycle, you don't have any unknown conditions such as gynae conditions such as endometriosis, PCOS, irregular period, then you can wait for at least a year if you're less than 35.
Okay.
If you're more than 35 years old, for the female partner, it's best to seek help after you have regular cycle, trying to get conceived after 6 months.
Okay.
But like I say, it's a guideline. There is no reason if you feel you are concerned at any time to seek medical help, otherwise from any doctors, either from your GPs, your gynae, or even straight to a fertility specialist, whenever you feel you have any concern at all regarding your fertility status.
Oh, okay. So, for example, if you have such as like gynecological issues, like your period is not regular, so you can actually seek earlier, help from the...
For sure. Yeah, for sure. Don't wait. I think one of the things I would like to, emphasize for those who are trying to get pregnant, do not delay treatment, right? Trying to get pregnant at an earlier age is faster, is easier and cheaper. Right. Yeah.
And it's also safer because like Natasha
definitely
said,
safer.
As you get older, the risk for the baby, for the mother also will be increased in terms of the pregnancy related complications, right?
For sure.
Okay. So in Malaysia, is infertility is considered a taboo? Sometimes we always see in the dramas, in the TV. They have showed that whenever you have the couple is unable to conceive, usually they try to hide it from the family. They don't open it up to their loved ones, okay, especially their close family. So what do you have to say in terms of this? How is the stigma affecting patients coming forward for help in Malaysia especially?
I think previously we do have this issue in terms that it's a stigma, it's a taboo to speak regarding subfertility, because nobody wants to be blamed for any subfertility issues. It can cause lots of marital disharmony. But I think with a lot of awareness, right, especially from well-known people, artists, right, where they open up and tell that they too face this problem, because like you mentioned, 1 in 6 couples do face some form of subfertility, so it's not uncommon. A lot of patients think they are alone in this, when a lot of people do suffer, and since now we have social media, a lot of awareness are creating, and I think this has break down the barrier in society to open up about things like subfertility. So a lot of people are, being open that I conceived through IVF. So
yes,
there's no issues in that. It's a natural. I did conceive. It still doesn't lessen me as a mother.
True.
It doesn't lessen me as delivering the child through even IVF or I had cesarean. It's nothing. So I think this is a great step forward for society to to reduce this taboo or stigma. So a lot of people be more open to step forward to say that I do have some issues, I need help.
Yeah. Because what I can see nowadays, even I have friends who are, who underwent IVF and also still struggling doing IVF. So sometimes they share with me in terms of from the Instagrams and also TikToks, because how it's so open in the Western countries. They even show their daily injections, even if it's not, because sometimes we are afraid to show it. The vulnerability of we're doing IVF, because in case that it doesn't be a success. But actually it's not something that we should be ashamed or be shy, isn't it, Dr. Natasha?
I think you can be open. Depends on certain people, right? I think it's good that you are open in terms of sharing. But if it's going to backfire, like sharing too much sometimes can backfire because it creates a bit of unnecessary stress for the couple. So I think it depends on the couple itself. If they feel comfortable about sharing, that's good. But if you don't feel comfortable, especially like you said, stress, whether it works or not, then maybe perhaps, you would probably keep it first and later share later.
True.
So it depends on the individual.
Okay.
But I mean, by them sharing, it opened eyes, and by sharing the experiences, other couples can learn and perhaps then go through the fertility or IVF procedure a bit more well informed. But I suppose don't scare yourself too much, because whatever other people are going through may not be what you will be going through. So be open-minded. Keep positive. Don't be too negative about certain things, because a lot of my patients go, oh, but I heard that a lot of people don't get pregnant the first time, and like I got pregnant the first time. So so you don't compare yourself too much. I mean, they do share during the social media, oh, how many I've got, what grade you have, and things like that. But I think sometimes it's not. It's not comparing between apple to apple. So you have to be prepared that anything, do ask your own doctor, because sometimes what they do, they ask another doctor who probably don't know your actual background. So there are pros and cons for sharing on social media, but like you said, lots of advantages. Also, we want to see some pitfalls sharing on social media.
True, because like we always say, if you are ready to receive what would be the comments and the backfire, if you are ready for that, then of course you can share it on the social media. But of course, I mean, a lot of them also learn a lot from them. I mean, those who actually gone through a lot of cycles, and because different cycle, I mean, different, every time you fail one procedure, you always have a different, I mean, the doctors will try to add on a different thing. So sometimes it's an eye-opener for those who are first-timer, or maybe those who are here in Malaysia. And so it's a very good thing for us to have all this like TTC group support, right?
Yep.
Okay, so since we have talked about, I mean, not just IVF, basically trying to conceive, normally what is the first step, since we know when this couple should seek for help, right? If they are having regular cycles for a year, I mean, they don't have any other issues, and if they don't conceive, so this is actually a red flag sign that you should actually start seeking medical attention. So maybe Dr. Natasha, you can share some of your journey also from personal point of view, from medical point of view, the first step for the couples when who want to start the fertility treatment. I mean, what are the things that they would be going through, and how long does it take from the first time that they appear at your clinic, and then doing all the tests and also whatever procedures which is necessary, and before the initiation of the treatment itself?
Right. Okay, I suppose it varies from where you are for your journey, and which facility, medical facilities you are, seeking treatment. Because obviously, when you are in a government setting, it'll be different from the private setting. In a private setting, it'll be different from whether you are seeing a general practitioner, a gynecologist, or you're seeing a fertility specialist. For us, for fertility specialist, time is important. We do not like to delay. We would like to complete all testing within the next 1 to 2 months.
Okay.
So basic testing needs to be a blood test, which will check blood group, make sure there are no sexually transmitted disease, there are no thalassemia, check your rubella status, check your vitamin D level, which is important for egg quality implantation. We then check your hormones, make sure there's no imbalance. Also then, that's blood test for both men and female, husband and wife. Then we'd also check for the tubes, right, whether it's blocked or not. So there are several ways in checking for the tubes. And the most important, but not, which we should forget, is the sperm, right? So from the male side, it's actually quite easy, because you need just a blood test and a sperm test done within one setting, right? But for the female, it's basically we need to follow the cycle. Right, so we need to follow the cycle. You have your period, so that's the early cycle of the period. Then it'll be different from the mid-cycle. So people go like, why are you scanning me over and over? Because different cycles at different phase is different. Where you are on your second day of your period is different from what the uterus and the ovaries will look like at your mid-cycle. And from cycle to cycle, from this month, January, February, March, it's different. Right, so we're actually monitoring and getting to know and seeing what you do on a normal basis, so we can anticipate
All right.
how we're going to move forward.
Okay.
Right? So we see lots of things. Sometimes they, would show, okay, this is the scan done by my gynae. I mean, it's not like a chest X-ray, so I will need to scan myself. I mean, I'm happy to see like chest X-rays and things, but for ultrasound, it's better to be doing the ultrasound myself. It depends on when I'm doing it, which cycle, right? So after that's done, I think that's within 1 to 2 months. It should be done.
Okay.
And depending where you want to move forward, depending on the results, you are ready to move towards treatment, which is suitable.
All right.
And it depends on how fast the couples want to move,
Okay.
or where they are. Like, younger couples, we can wait. But sometimes younger couples don't want to wait anyway. So actually, I will have to then depend on the patients, what they want to do.
Okay.
And some couples would want to do things faster. Like they go like, what, IUI 10-15%, forget about it.
Okay.
I want IVF, I've got, the means, the social means, I've got the money, I want to move fast. So we actually do then recommend accordingly.
All right.
Yeah.
Okay.
So things to anticipate for gynae, we do scans, and majority of the time we do vaginal scan.
Okay.
Right. Then you can only see accurately and clearly the ovaries. So be prepared that we'll do a vaginal scan. So most of them, I think one of the things they are not prepared, like, oh, you're going to scan me now, like today, like yeah, why not? I mean, you're here. It's difficult to take time off from work, right? Which is another important consideration. You will need to make allowance for time, which a lot of people are working. So we need to make sure that whenever we see in clinic, we are doing whatever we can so that we minimize time in clinic and clinic visits.
Okay. Right. You were mentioning just now about the like in the women, I mean females, we have the biological clock in terms of their eggs.
Yeah.
So is there any blood test that actually can tell not really how much eggs is left, but what is probably, am I in like in the group that the eggs is sufficient enough, or how is it? I mean, maybe you could just tell us, share with us about that.
So we do have some investigation in order to, maybe perhaps advise a female or a woman where you are at for your fertility potential. So there is one blood test called AMH, which is anti-Mullerian hormone. It basically measures the hormone that is released by the follicles, which is inside the ovaries. It tells us the number of the eggs, but it does not tell you the potential of you becoming pregnant. Okay, so you have to sort of take into consideration not only the level of the blood test, but you would also correspond to the scan. Because another way that we check also the number of eggs, we do a scan. That's why you need to do a vaginal scan, and we count the little round cysts in the ovaries. Right, that's called antral follicle count. It will vary, right, from cycle to cycle, but we roughly will have an average sort of number. So usually I'll count right and left follicles. I'll go, okay, you've got maybe 10. And some months you've got 2, like a bad month. So we don't start cycle like IVF on that month. All right. So this one, but bearing in mind, patients will go, can I get pregnant? Until you actually really try to get pregnant, you will know whether you have a problem or not. But I would advise, based on people go, so should I take an AMH or not? Well, I think you should. You should do AMH, you should do the antral follicle count. And AMH, studies have shown if you have less number of AMH for your age, then maybe you will have a bit of delay in conceiving. Right, so we want to take the necessary precaution. Like if you go like, I'm 29, I want to get pregnant at 35. Like, shall I wait? So that's some of the questions that go. So we'll do this assessment, but bear in mind that things change according to your lifestyle, according to your genes. So this is sort of like a snapshot. So if I say like it's good at the moment, right, but whenever you're ready, don't delay. Fast is better, younger is better.
Okay. So it's AMH for those who wants to get themselves screened. I mean, they have AMH blood tests which can be done in the government settings, in the private settings, but make sure that's just a number that they could just tell you probably roughly how many eggs are you in a good side, that your eggs is sufficient enough, but that it doesn't go like proportionately that you will get pregnant based on the numbers. I mean, of course, if it's lower, the chances would be lower, but having a sufficient amount, that does not mean that, if you do IVF, it will be confirmed 100%.
My advice, you have less number of AMH, go seek a fertility advice.
All right.
Right, so then we can have a chat. We can, assess better.
Okay.
So because sometimes you have low MH, I can see in the social media, a bit of sharing. My MH is low. This is the end of me. I will never become a mother. So I think next best step to take, if you're at all worried, especially if your AMH is low, seek specialist treatment, fertility specialist treatment, so that you know where you are and we can do the necessary treatment which is required.
Okay. All right. So that's a take-home message for all those ladies out there. So since you did mention something about IUI and then we also have IVF, this is especially the terms that is very, very common for those who are in the TTC journey, okay, trying to conceive journey. So maybe you could break down to us the difference between IUI, intrauterine insemination, and also in vitro fertilization. Just by the name, of course, you know what is the difference between those two. But which group of patients maybe they can try with IUI, some of them with IVF, and what would be the success rate between these two?
Right, so IUI basically stands for intrauterine insemination and IVF is in vitro fertilization. So the fertilization occurs outside for IVF and the fertilization occurs inside for IUI. So IUI is super simple. Basically, we will put the female partner or the wife on some medications, fertility tablets, just to make the eggs a little bit, 1 or 2 enough.
Okay.
And then we then monitor the follicles, and once it gets to a certain size where the egg is mature, and usually this falls anytime between day 11 to day 15 of the cycle, means she's ready for the process. And we give 1 injection to basically make the egg ovulate or rupture, and it's fertile time, and the husband on that day would then come to the lab or the fertility center or bring it from home, and we'll just inseminate processed sperm, which means we basically take the best swimming sperm or the fastest moving sperm so that we get the best pregnancy rate inside the uterus. Now how we put it is just a very small fine plastic catheter, put it through the vagina, through the cervix, feels like a pap smear or less painful. Okay, so it's really super simple. Then you will wait for 2 weeks whether your period comes or not. If your period does not come, possibility you may be pregnant. Okay, and we have very simple tablets after the IUI. Super simple. You can continue your activity as usual. Pregnancy rate unfortunately is about 10 to 15% for each cycle. For the younger ones, cost maybe roughly about 2,000 to 3,000, depending on how much hormones you're using and which setting you are doing. Now for IVF, it's different. It's much more strenuous. You're going to start on your 2nd day or 3rd day of your period. Depends on the protocol, but majority of the time, 2nd day or 3rd day of your period, and then you'll be injected. Okay, injected daily. I'm sure you've been through it, right? The majority will be injected daily for at least a good 10 to 12 days with scanning maybe 2 to 3 times in between. And on the day, usually again mid-cycle, anytime between day 12 to day 16 of the period, you will be ready for an egg pickup. It's all done as a daycare procedure, nothing at the tummy. You will be asleep, right? A light sleep. So you won't have any pain, and will be then the needle will go through your vagina, nothing to the tummy, you're asleep, half an hour procedure, you go home at lunchtime, most of the time. So no need to stay overnight in hospital. Then we do the fertilization in the embryo, the embryologist in the IVF lab, and usually we'll wait at least 5 to 7 days to see how many total of fertilized egg, or what we call embryo, that we are able to vitrify, or what we're able to freeze and utilize, right? So then, after that, usually it's going to be either a fresh or frozen embryo transfer. Now, fresh means anytime between 3 days or 5 days after the egg pickup, you will have a transfer. Procedure similar like an IUI, similar like a pap smear, usually I say. Super simple, no sedation. You'll be fine, right? You don't need the sedation, right? And then after that, you will wait and you'll be giving some medication. Some is oral form, some are vaginal suppository, some may require injections. Okay, so you will then do that for maybe 10 to 12 days. Do a urine pregnancy test or a blood test. Okay, so then you will know, whether you have conceived or you have not conceived. Now, pregnancy rate depends on the age of the female. 30 to 39 years old, we are looking at 40 to 50% pregnancy rate. But overall, if you see, it's 30 to 40. In a good lab, in a good center, we're looking at 40 to 50%. Between 30 to 39 years old of the female partner, it will drop. At 40 years old, we drop to 27%, and drop much, much faster. Statistically, more than 45, your pregnancy rate would be less than 1%. Okay, so that's something that we need to always tell the patient. Some of the myth, if they do IVF, is 100%. It's not, right? So age then comes into the matter, and sometimes you go, doctors trying to push me for IVF. No, we're looking at your age, right? We know this is the things that we experience statistically and also on a day-to-day basis. We do struggle when the wife's age is much more older.
Of course, we know about the ovarian hyperstimulation syndrome, right? OHS, which most of those who are going through IVF, they would be worried in terms of that. What are the percentage and what would be the symptoms and what is it actually?
Okay, so one of the more important potential complications is called ovarian hyperstimulation, because when we actually do IVF, we are stimulating with hormones, and that would make the eggs grow. Right, and not only one egg, all of the eggs grow. So ovarian hyperstimulation, when there is overstimulation of the ovaries, and that would lead to changes in the bodies, where there's accumulation of fluid. Right, becomes our blood vessel becomes leaking, and there's accumulation of fluid inside the body cavities, such as the stomach, not the stomach, actually in the
pelvis.
Pelvis. It could be also in the lungs. Right now, this is perhaps more of it's going to be a pass, because the way we stimulate and the way we identify patients. Now, those who are high risk are young patients with high ovarian reserve, PCOS patient, and those who are thin. Right? So this will be the patients that we would identify as being high risk for developing ovarian hyperstimulation. We need to identify and then take the necessary precaution, use either lower dosage or change their regime, and monitor them closely. The way we trigger it also have been a game change, that we trigger with a different medication that would actually potentially eliminate the risk of OHSS. So you might be feeling a bit bloated. So what happens is common symptoms would be feeling a bit bloated, right? But and your tummy will be distended, like you're feeling like pregnant, right? But the things that we don't want is becoming short of breath. Right, short of breath means there's probably over distension, or maybe there's some lung accumulation. So those it can be fatal. It can also cause blood clots in the legs. So these are potentially fatal conditions. So the most important things are the steps taken, right, during the procedure itself. Right, when we're stimulating, we're already monitoring closely the way we trigger, right, the last injection to make sure that we trigger. We use specific medication and monitoring, close monitoring. So I think by doing all those, you probably only have mild OHSS, right? But the fatal ones, the really bad ones, maybe 1 to 3%. Which we are, I think, with all this intervention, it's probably become like non-existent. So those we need to be, fertility specialists are good, well trained. So we don't have this like majority. Alhamdulillah, right? So because it can be quite worrying. So like the last time we had COVID, so we're stimulating, and sometimes if they have COVID, we actually have to abandon the case. So not good, because all the eggs are inside, and so I'm glad we overcome that. So what we do, we need to prioritize safety over getting pregnant, unfortunately. So less perhaps sometimes is better, and identifying those high risk groups are very important, and to make sure that we have a 0% moderate to severe OHSS in our clinic for IVF.
All right. Okay, so you did mention regarding the success rate for the IUI is about 10 to 15%. For IVF, it's about, depending on the age mainly, but if it's about 30 to less than 40, it's about up to 39 years old, it's about 40 to 50% in a very good center, 30 to 40%. So, it's some sort of, it's not logical if a place or a center would claim that there would be 100% success rate or like 98%, because that is a bit too high overachiever, right?
I think you go like, are you sure? It's impossible. I think even for the younger ones, less than 30, we may look at 60, 70%. I think in some centers, if they say that, some centers say, go like, yeah, you're sure. But I think it's audited. We do achieve 60 to 70% in the less than 30 years old, because they have good egg quality. infertility. It's probably just the tubes are blocked,
Yep.
or it's just some sperm issue which will be overcome by the IVF procedure itself.
I understand.
Yeah, so some people, depending on their statistics, but we do have in our center where we are comparing our success rate and benchmark it according to the New Zealand and Australian IVF centers.
Okay.
So Alhamdulillah, we want to maintain to be at the higher international level with our success rate. So Alhamdulillah, we are doing quite well.
All right.
With a lot of hard work, mind you, a lot of teamwork. So it's not easy. And there is a lot of high expectation from patients, which we would strive to do our very best. But like I said, it's not going to be 90 to 100%. You may need to do several cycles, but we aim to hopefully minimize and shorten your journey towards parenthood, because it's really important to not delay the pregnancy, being too long on a fertility journey, because a lot of patients will probably, stop doing it. So we want to reduce all this and get you pregnant soon.
Yeah.
Yeah.
Because sometimes if you keep on trying and you don't, achieve what you have been trying so hard, so some of them would just have mentally, they would just be tired, or they just want to give up, isn't it? So I do understand the importance that Dr. Natasha is trying to advocate here, that time is essence. So do not delay. They will just push it, because I remember going for her talk, she's just like, okay, I'll try probably once IUI. If it doesn't work for you, straight away IVF. It's like, so we can see the point there. We were talking about the success rate, but how about other things? This is all talking about the internal, or maybe the quality or the age. How about other external factors? For example, we talk about the lifestyle, the stress factors, exercise, yoga. Nowadays we have acupuncture as a supplementary. There are papers which have come out regarding this. So how would that contribute to the success rate?
So whenever a couple comes for fertility, actually we do a lifestyle intervention, right? You will assess their lifestyle. You will also start from basic things like, it's important to take care of yourself. A lot of people, I think we are, it's stressful. It's stressful. So we sometimes forget to take care of ourselves, right? So we need to start from basic, taking care of ourselves in terms of eating healthily. Right, majority, that's how we do have our obesity epidemic, I would say, on the rise. People are just eating far too much and unhealthy food and processed food. Get back to basics. Eat lots of, balanced, healthy diet. Make sure that the portions are good, and make sure you're not eating like at the late night, right? Okay, so we do that, and then we need to sleep. Right, you need not like 8-10 hours like sleeping whenever. We actually do have biological clock in terms of where we should sleep in order to get the maximum. We need our body to recover. Right, so I usually tell the patients, look, what time do you sleep? 12 o'clock. That's seriously late. Like, I wake up at 8 still. You need to sleep earlier. So we're looking at maybe 10, 11 o'clock. Wake up early. Early is always better, right? And then your body get into the, the rhythm, and they would probably repair themselves better. You probably have less issue with obesity, less issue with, having issues in sleeping, right? So all those things, smoking, vaping, same. Right, you can't have both of those. Smoking and vaping is bad. We'll also obviously supplement because we can't have a lot of things from our diet. So we do supplement. So minimum for those who are trying to conceive, folic acid, a good multivitamin, fish oil, vitamin D. Right, and for egg quality, we'll probably add on coenzyme Q10. For those who have PCOS or PCOS, we might add on inositol, right? So all those you need to then discuss with your doctor which one would be suitable, right? So I know it's a lot of tablets sometimes, but those are the things the simple things that we want. Exercise, because that helps in terms of perhaps reducing excessive weight. It also gives you happy hormones, help you sleep better. Okay, and we don't want you to do excessive like marathon, things like that. And it's not the time to do marathon when you are trying to conceive, because it then creates additional hormone, which is cortisol excessively. So we want you to do moderate exercise, maybe half an hour, 3 times a week, and that will be adequate, right? And do whatever you want to do. Yoga, you can do, walking is good, you like cycling, swimming, all those are good. Just see what you want to do. Stress, people say, oh, I'm stressed, that's why I'm subfertile. And also the fertility treatment will give you stress, right? So what we're going to do, we're going to like see, you know your own body, you know your own situation. We need to manage stress. Lots of studies have been shown whether, whether stress causes subfertility. It's difficult to do that. A lot of different contradictory studies. But to me, I think minimize and manage your stress as much as possible. You will have stress, right? You can't be stress-free 0%. So we're just going to minimize. You know, if it's going to be your work, try to see whether you can find some balance in your work. Try to see whether you can get some more flexibility, right? Maybe negotiate with your boss, right? Because eventually we need that when you have a child.
True.
Right? You need to adapt anyway, and you need to change anyway. What's better than to start
now,
slowly now? Before you have the child, because it's going to be a whole different lifestyle. You need to adapt, right? So all those things are important. So lifestyle changes is definitely one of the things that we will cover, right?
Okay.
Yeah.
All right. So remember, be a part of the 5 a.m. club, because sleep early, wake up early, not the other way around. It's basically because they say this is an important time where your cell regenerates are about that midnight until that 3-4 o'clock in the morning. So it's okay for you to sleep early, but you can wake up at 4 or 5 o'clock. That's good enough for, I think, it's good for the hormones and also for the revitalization. So maybe you could just share a little bit in terms of the advances in the technology in Malaysia, because now we have heard about PGT, pre-implantation genetic testing, and then we also have ERA. Okay, so sometimes in those people who are like they treat IVF or fertility journey like an exam. So what are the checklists that I have to do? Because I do get questions. Because we do discuss among those who are T2C warriors, right? So what do you do, or what your fertility specialist say? What do you have to say in terms of that? What is this PGT? What is ERA? Who needs all these things actually?
Okay, for me, the advances in IVF, to me, the best would be if you can have only one injection for stimulation, one injection for trigger, and that's it. Right? That would be super fantastic. But I suppose a lot of advances, we want to make IVF treatment or fertility treatment as patient friendly as possible, with less injections important. Make it more flexible instead of waiting for second day, third day. Make it more flexible, and also the duration, and obviously the increase in success rate. Lots of advances. Obviously, when they first come out, you'll be like, wow, this is it, this is the game changer. But with time, a lot of all these advances doesn't improve as much as we hope for. So that's why we go back to the same basic things. Preparation is important. The couple needs to do lifestyle changes, things that they can do and do not delay, seeking treatment. Age is still plays a very important thing. Now, if they fail the IVF, then we're talking about why it fails. So even though the embryo place is nice, right? It looks, wow, grade A, beautiful, but you're not pregnant, right? So this is where sometimes that we have the PGTA. So PGTA is for those who have doing IVF treatment, where we can actually biopsy the embryos which are day 5 or day 6, right? And say whether it's chromosomally normal or not, right? Unfortunately, it's not 100% perfect. The technology itself is a bit, you need to get to day 5, day 6. And a lot of patients have quality issues with the egg and the sperm. They can't make it through day 3. So lots of people have go, oh, did you do day 3? Why? We do like day 5. If you have day 5, is that's ideal situation. A lot of patients don't have day 5. And the technology is for the PGTA, for the biopsy or the genetic testing to be done, it has to be day 5, day 6, right? And it's not all day 5, day 6 are suitable. So then that becomes a bit of an issue. If it's an ideal situation, you have available those embryos, then great, it's chromosomally normal. So we can put it. Again, it's not going to be 100% pregnancy rate, nor it's going to be 0% miscarriage rate. Ideal situation, at least we know we put in a normal embryo. If you have a miscarriage, or if you're still not pregnant, we go, hang on, why is that? Take a step backwards and say, are there any implantation issues? So then we'll do other testing, which is not the first line of investigation.
Yep.
That will be like second line, third line. Okay, then we'll see blood tests, error. Unfortunately, the evidence base is dropping, going down. So I put that last on my list, right? Because error is basically where to see where we can do a biopsy, send it off to the lab, and see whether the timing for implantation is correct, right? So unfortunately, studies, it's still conflicting. It's not strong yet. So we do PGTA first, if we can. Then we sort out other things first. If it's still not pregnant, then we may consider ERA as one of our other testing, especially if you've done a PGTA embryo and you're still not pregnant. We may or not consider, because all of these advances have costs attached to it. So we're just going to have to balance whether we're going to tick everything. Yeah, it's beautiful to tick everything on the checklist. It comes with a price. Unfortunately, we need to then see whether which has far more beneficial, has associated with increased effectiveness and success rate, right, for the patient.
Okay. All right. So ERA is like basically take a biopsy from your endometrium and see whether the lining is suitable for you to
the
implant.
timing is suitable or not. Yeah.
Okay. All right. So, but like what Dr. Natasha have mentioned, you cannot take away that from the basic investigation. So, and it differs from patient to patient, as those who have failed failure of implantation, then maybe the fertility specialist will go a step forward. I mean, those kind of things. But it's not all patients have to do all this as a checklist. They have to do PGT and everything. Because if it's the first time, normally you could just try probably without PGT, right?
Depends on the age. Like guidelines have been shown, if the couple is more than 35, is less than 35, the PGT does not change their success rate. So there's no indication unless they have recurrent miscarriages, recurrent implantation failure. Yes, we may consider. Or else, less first time, no issues in terms less than 35, it's not indicated.
And you have also seen a lot of day 3 embryos a success, isn't it? Like
for sure. Like they go like, I've got everything been pushed to day 5, nothing. So they've done all those injections and all those procedures with nothing to transfer. So then of course your pregnancy rate be 0. So I think those who totally advocate everything to a blastocyst, maybe it's not in all situations, because now more and more on top of the PCOS, we have egg quality issue, we have sperm issue. The problem with that egg quality, we can't see from blood tests. We only know after when we do the egg pickup, right? So it's even in younger women, I think it's just our environment, we are getting more and more poorer egg quality. So we really struggle, even though with IVF, right? We really, really struggle.
Okay. All right. So from your experience, is there any common myths? Okay, we talk about taboo. Now we talk about myths in terms of IVF per se. Not just because IUI, maybe not as much, because it's almost similar like a normal pregnancy, just that you just get it at the right time. But IVF is totally a different game, okay, ball game. So sometimes in the IVF babies or the mother, what would be in terms of, are they at a higher, having health risks in terms of, especially because they are loaded with hormones, isn't it? The mother would be loaded with hormones, injections, especially those who, in terms of the hormone-related cancer, such as breast cancer, endometrial cancer. So what would this population of IVF mothers, and how about the babies? Is there any side effects on the babies because the mother is being injected with loads of hormones?
Okay, I think in terms of that, there's a few things in terms of hormones. Fortunately, studies have not shown that the IVF treatment, with giving hormone has caused, consequences, adverse consequences such as cancer, which is very important, right? Like breast cancer, uterine cancer, cervical cancer. It has not been proven, so that's good. In terms of adverse effect, like potential in terms of abnormal babies, not significant. Right, so that's something good, like autism and things like that. We actually really don't know. It goes back to, it is known that subfertile couples may have some genetic cause, right? So that could be also a confounding factor, causing them to perhaps have a bit more fetal abnormalities, because they're one of the reasons they're subfertile. They have some genetic causes. right? And another thing also, if they do get pregnant, because we increase pregnancy rate, and they're actually a bit older, like I mentioned. Yep, older fathers do have increased risk of having child which would be potentially have increased risk of autism. So so far no studies have shown that there's an increased risk of all these cancers and also adverse effects on the offspring, which is good. Yeah.
How about super babies? Like sometimes people always say in terms of, sometimes IVF is not just because they want to conceive. Sometimes, I mean, I'm not sure how is it in Malaysia, but in the West, sometimes they can basically construct what kind of babies or what is your offspring. So what do you have to say about super babies?
I think so far not yet. We probably, which is not legally in Malaysia, we probably can see girl or boy, but I think we can't choose yet the genetic. But I feel that because it's perhaps, the couple was, really looking forward to the pregnancy. So after delivery, they might be eating better, taking care of health, the changes, and then they perhaps be more, attentive to the children. So it seems that the children is like intelligent, have all these positive benefits, but perhaps all these little other things has actually contributed to us seeing, super babies from IVF babies.
Yeah, sure. I think all those who are ongoing the TCC journey, it's such a precious, I mean, if you get pregnant and you have the baby, it's a precious pregnancy. So I think most of the future mothers or those who are going through the journey, they would actually let go most of the things, even their career, just to really focus to become a mother. I mean, Okay, you were mentioning regarding you are practicing in the private sector. In terms of the cost and finance, I mean, like, how is it in Malaysia as a government? I mean, the government subsidizing, or I mean, like, because the cost, I'm sure it's about roughly 15 to 7. I mean, to begin with, of course, with the additional tests. At least about 2 to 5Ks. I mean, even to freeze the embryo also is another different cost, right?
Correct.
So, are there any government support schemes or initiatives that they have done that could ease in terms of for the future couples?
Right. So we do have support from the government, which is good. I think we're waiting for it, and finally it came out. We can take out the EPF money. I think that has actually allowed lots of younger couples to start their treatment, right? So that's really good in terms of you can take from your account 2, now you have the account 3. So at least that is the financial burden, then they don't delay their treatment. Okay, so that is another one also from tax incentive. You can claim, don't quote me, but maybe about 8,000 per year for fertility treatment. Now, the good thing now that's from the government side, also now insurance also are probably going to start covering for fertility.
Yes.
Because lots of overseas now, some of the company, they do cover for fertility. So I know lots of Japanese companies cover. I think also for overseas, I think from the Saudi, some of the embassies do cover. So I think that's a really good initiative because, I think now, I think certain countries are giving like a really, money basically because their population is so getting such an alarming rate going down that they're giving incentives for you to have babies. Perhaps a 4-day work, right? Things that, I don't know, we're already working 5 days. Maybe, I think maybe if that's 4 days work, but I think not only to get the baby, those who are, already have the baby. Because once you have the baby, for the second baby, it's really quite a struggle, right? We'd like to maintain the female in the workforce. I mean, lots of female would love to continue career, but you really, really struggle, right? So if there is things like, daycare at the family, at the work, affordable ones, right? So that would be really good. A good, affordable daycare center is great. Other incentives like, leave, maternity leave, parental husband also leave, all those would be good, right? Flexibility in the job. I think that would also encourage more couples to have more children, to have a bigger family size. Also, I think cost of living, cost of education, it's really important for government to have more incentive. I mean, good start, EPF, great, but if you can have more other incentive will be much more welcome, right?
Yeah, because I think nowadays Prudential also starts covering for fertility. For fertility, yes.
That's good. That's a good, really, awareness from them, so that those who have just starting taking the young couples, right? You go ahead, look at the insurance, and it will be covered for at least, I think, 15,000 or something like that.
Yeah, so because nowadays in Malaysia, slowly it's an eye-opener as compared to the West or other countries that Natasha has mentioned. So I think slowly it's getting into the system that they are covering for the IVF treatment, right? Okay, just coming to a little bit the last two questions. This may be a common concept in the West, but not so much in Malaysia, maybe. Or just it's not being publicized much. Is egg freezing or sperm freezing a good idea for people? Because, like, for example, they have, like we just mentioned, those who got married early, but they don't want to have the children yet. But as time passes by, the quality would drop. So, do we have? Can they actually freeze their eggs or their sperm? And how about those who are not married? I mean, who does not have any potential yet to get married, and they want to preserve their eggs. How is that?
So for Malaysia, the guidelines are egg freezing for non-Muslim. Okay, and also for Muslim, actually, unfortunately, not yet.
Okay.
So you can't freeze the egg.
All right.
But I think there are reasons for, if there's health reasons like cancer and things like that. So now egg freezing, I think has not. We thought it would be catching up and everybody will go and freeze my egg and things. But actually the trend has not catch up.
Okay.
Like there is still a low pickup rate for egg freezing, even I think for Malaysians and the non-Muslims.
Okay.
Not so much. I think it's partly due to cost.
Okay.
It is quite expensive and it's not a guaranteed thing that you freeze your eggs, you will have a pregnancy. Okay, you need to aware that we are freezing the eggs.
Okay.
Sometimes we need a bigger number of eggs because we need to fertilize it. So like for embryos, maybe you can freeze maybe 3 or 4.
Okay.
It's already a fertilized egg.
Right.
Now eggs, when we freeze it, you need to be fertilized with the partner's sperm.
Okay.
So not necessarily, it's not like a insurance, like for sure I'm gonna have a baby by freezing my eggs. So all those things, probably with the cost issue, would have has led to not such a high pickup rate of egg freezing. Not such a popular thing that we thought it would be like everybody will be freezing, and cost issue. And actually, if you want to freeze eggs, you need to be at a younger age, preferably late 20s, early 30s will be good.
Okay.
Right. Unfortunately, sometimes when they come for egg freezing, they'll be like, okay, I'm 40 now, I'm ready now. You go. There's only 1 or 2 eggs there to freeze, and you need probably like 15 or 20 eggs or more, at certain age. And we've seen stories like, freezing because of career or not ready. So when they get to 40, meet their ideal partner, fertilize it, and there's nothing to transfer. Right? So it's such a heartbreaking to me. It's not going to be an insurance policy for you to, secure your motherhood. So when you're ready, again, do not delay, because we need to put back in. Because sometimes we have a normal embryo, put it back in, no pregnancy.
Yeah. Because at the end of the day, it depends on the age of the mother as well. When they conceive, so it plays a big role, not just
the eggs.
Not just the eggs. And at the same time, like you said, it's different if you freeze the eggs, because I also have the concept that when you freeze the eggs earlier, so it will be at, for example, at the age of 25. But the most important is, it's different when you already fertilize it. So you freezing an embryo is different than freezing an egg. So,
sure.
So the success rate would be more if you have an embryo being frozen at that particular age.
Right.
Then after that transfer, you can probably delay it a little bit. But having an egg freeze at an earlier...
I've got a lot of patients coming at 40, like frozen their embryos and had twins maybe. So they come back like maybe 4 or 5 years later. So now they're like 40, go like, how now? I mean, like, I said, well, you've got young embryos, embryos from your younger age. But of course, you're 40. Make sure that you are fit and healthy. Optimize your health. Obviously, it carries also the risk when you've been 40. Implantation issues might reduce, and also, hypertension and diabetes, right? So all those things you need to take into consideration. So we are now having patients coming in to complete their, embryos, whatever whatever they're frozen. So it is a bit of a dilemma,
Okay.
right? Whether shall I transfer or I keep it or throw it. So all those things, when you freeze your embryo, right? This is something that you want to think about. But embryos are not a living thing.
Okay.
From Muslim part, we do discard embryos if it's abnormal. So you need to speak to your, head religion, because I think different religion have different opinions. Some say embryos are a living thing.
All right.
So we can't have access embryo creation.
Okay.
So we then have a discussion with the couple whether this is permissible in terms of their religion.
All right. Okay. So just want to clarify. You mean that even in a Muslim couple which are married, they can't freeze their eggs? Can they freeze their?
Well, if they are married,
Okay.
It's better to freeze their embryo.
Embryos. Okay.
So they go, I want to freeze my egg, but you're married.
Yeah. Might as well just freeze the embryos, right?
But then it belongs to both.
Okay.
Right? It's an embryo, it belongs to both.
Okay.
If one of the partner dies or the partner actually separates or divorce, you can't use it.
Okay. So basically you have to discard if any.
Yeah, you can't
Whichever.
use without the other person's permission.
Okay.
Even though it's half yours.
Yeah. All right. So lastly, before we end our session for today, this is a very, very interesting topic. What would be your message to the couples out there who are feeling lost or maybe ashamed or maybe devastated after several times that they have tried through this TCC journey and they have not managed to have a child? So what would be your message to them?
Okay. First, you are not alone. And seek help, right? Support each other, right? And get to the right help. Like if you've been trying long, go and seek fertility specialist help, okay? And do not delay, right? I think with a lot of patients, they give up hope too early, right? Be consistent, love yourself, take care of yourself, and do not give up hope. Right, be persistent, and inshallah, majority of the cases they do get pregnant, right, and they do have their dream child. So I think this we need to be open about it, right?
True.
So yeah, so my prayers for all those couples trying out there, don't give up hope. Inshallah, be persistent, and then seek help, and we will try to support each other, right? With a lot of patients, I feel for them.
Yeah.
Like they've been a long journey, but sometimes they feel, oh dear, long journey, clomid, and it's not the right treatment, right? So we move to better treatment, get their pregnancy faster, so that we can get your pregnancy faster without having all this emotional roller coaster, right?
I understand, because I remember one of my friend who told me, I still remember from the initial time when I wanted to start all this TTC journey, as long as she's not menopause, as long as she still can financially pay for the treatment, she would go all out about it. So I think that would actually keep all of the ladies, females out there to keep on going. Before we end, to all our audience, don't forget to follow all Sinar Daily social media platforms and also download Sinar Daily's new and improved mobile application. So before I end, in a nutshell, just a few notes I would say to all the TTC fighters out there. Never give up, never surrender, continue praying. Inshallah, you will get there. And IVF is not a race, it's not an exam, it's a journey. So you have to embrace it. So I'll see you guys again in our next session next month, inshallah. Assalamualaikum.